Please start.
So good evening, everyone. So it's a great pleasure to welcome you all. Advances in Common Cancer Care is the day 2 session. So I would like to invite Dr. Abhinav Navaria sir for give his opening remarks. So it's over to you, sir.
So good evening, everyone. Yesterday we had a amazing discussion on head and neck cancer and lung cancer, and starting with day 2 today. Today also we have some exciting presentation, panel discussion by Dr. Sahu, in which he's going to discuss about triple negative breast cancer. Welcoming you all, Dr. Sahu and all the panelists, Dr. Atul Sharma, Dr. Shaunak Balame, Dr. Rajit Radhan, Dr. Rashmi Bansal, Dr. Mohit Saxena. Thank you for joining us. And now let's transfer everything to Dr. Sahu for a panel discussion. Thank you, sir.
Yeah, thank you, Abhinav. Thank you for the invite. I'm audible.
Yes, sir. You're audible.
Yeah, and do I have all the panelists? Gitika, can you guide me?
Sir, Dr. Pallavi ma'am and Dr. Chandrani ma'am is not there. Rest is
Dr. Pallavi is not there. Dr. Chandrani is not there. That's fine. Dr. Pallavi, Dr. Chandrani. Okay, so my slides are full. The slides are properly visible.
yes, sir.
Yeah. So I think we are starting at 7:15. We have 25 minutes panel. So I'll try to do as much justice to this panel as possible. We have been given the task of discussing advanced triple negative breast cancer. So that is what has been given to us. So let's see what we can do about it. Again, thank you, organizers. So we'll go directly to the case. So we have a 45-year-old female, no family history, presented with left-sided cancer breast, triple negative, ER/PR HER2 new were totally zero. I'm not speaking at this point of HER2 low. So please let's keep that out. It's HER2 zero, and not even ultra low. And we have a bony metastasis, we have lung metastasis, the PS is 1. So Shaunak, how would you like to proceed? Very quick, brief, short answer. Shaunak, you're there? Rajit? Mohit?
Am I audible, sir?
Yeah. So Rajit, please take it up.
Sir, 45-year-old female with PS1 and triple negative breast cancer,
Advanced
metastatic
triple negative breast cancer.
breast cancer. So systemic therapy, yes, possibly including.
How do you proceed? Any test you require, anything which you require, or you directly want to go for the systemic therapy?
I would do the general investigations that we do routinely,
Done.
KFT, LFT. We
Apart from that, Rajit, anything else?
we have the biopsy as well.
Yeah.
Might as well do a PDL1 test with IHC.
So you want a PDL1 testing, okay?
And
Anything
a
else?
BRCA mutation analysis of the patient.
Okay.
He's young.
And PDL1, may I ask you what antigen would you use?
DACO 22C3, sir.
22C3. Okay. Okay. Let's so Mohit, any different of opinion at the initial evaluation? We have done a PET scan. We have and Rajit has done a PDL1 testing with 22C3, and we have a BRCA or HRR mutations done. So that's what Rajit spoke about. Anything more you want to have, Mohit?
No, sir. To begin with, I think this is sufficient for me.
Sufficient for you. Okay. Shaunak,
To
you are
begin
there?
with, of course.
Yeah, that's fine. That's fine. Okay. So
Yes, sorry, sir. I was in a bad reception area.
no problem. So I hope you are now there. So you can keep your video off so that the feed is nice. So now Shaunak, yeah, that's fine. I see you. So BRCA is negative. The PDL1 is 20%. So Rajit, we have this now with us. So Mohit told no, nothing else required. Rajit does not require anything. Shaunak, you require anything else? We have lost him again. Okay. Rashmi, you're there? Okay. Dr. Atul, I could see you.
Hello, sir.
Yeah. So anything more you want? So BRCA is negative, PDL1 is 20%.
Sir, usually this information is good enough to proceed, but
Okay.
in my
Just to
practice,
assess the
I
fitness
do
for.
and
Yes, I think there's a bit of delay from my end.
Yeah, that's a big delay, actually. That's okay. We'll come back. Okay, so basically what I get from the panelists is they're pretty happy with this investigations and they would like to proceed to the systemic therapy. So now we have these systemic therapies in options given to you. Shaunak, can you quickly tell us which one would you go for? Finances is not the issue. I do not want to put finances here. Shaunak.
So if finance is not an issue and it is 20%, then ICI with sacituzumab is as per the latest ASCEND-04 trial.
So you will do a chemotherapy with ICI with sacituzumab and your immune checkpoint will be what?
Pembrolizumab.
Pembrolizumab. Mohit, any difference of opinion?
So we have ASCEND for data set. So I think sacituzumab plus ICI that will be sufficient.
So
I
you want
think-
to go with a chemotherapy with
No.
immune checkpoint only.
No, I am talking about immune checkpoint, Pembro plus sacituzumab govitecan.
So you are going with only sacituzumab govitecan and immune checkpoint. That's what you spoke.
Yes, sir.
Okay. So Mohit is with the ADC and the immune checkpoint. Atul, what is your choice? Okay.
Hello, sir.
Rashmi,
Sorry, yes, sir. Somehow there was some technical error. I was
that's
not
okay.
able to unmute
So
myself.
Rashmi,
Yes.
Sir,
yeah,
just
Rashmi,
for a
can you
second,
take this question?
for a
We have a
second.
triple negative metastatic breast cancer,
Yes,
BRCA
sir.
negative, PDL1 20%. And this is the treatment choice, a 45-year-old fit female.
PDL1 20%, sir.
Yeah,
So yes, upfront pembrolizumab with the immunotherapy. If visceral crisis is there, then I'll go
no,
for
there is no visceral crisis.
then BRCA negative patient, sir.
Yeah,
So taxane plus pembro.
okay, done, fair. So you would go for a taxane plus Pembro. That's what Rashmi is all about. Atul, I could not hear. Rajit, quickly.
The third option seems appropriate: chemotherapy with ICI plus SG.
Can I ask you one thing? Two of you have told, I understand where it is coming from. Ascent 4 is with the data set all of you are banging on. So if I remember correctly, and I have the slides, the overall survival was negative, which was although a later endpoint, the primary endpoint was PFS. So do you think with this data set of OS being negative, you are very comfortable to expose every patient to a chemotherapy with immune checkpoint with sacituzumab upfront?
Sir, frankly, no. I would sometimes keep my chemotherapies for later or SG for later as well. But since it's a young patient, seems to have a very good disease burden or a high disease burden. You mentioned two sides of
Decently high, not that high. A few lung mets and a bony mets, and that's what I mentioned. No liver mets. You do not have any visceral crisis. The performance status is still 1.
is still one.
Yeah.
So yes, I mean you're not wrong in starting chemotherapy with ICI as well.
Okay.
That
So what I get from the panel is there is definitely a choice of immune checkpoint that's coming in very clearly to all of you. Chemotherapy is definitely there. The only difference is that should I add a sacituzumab govitecan to front line or should we preserve it for second line? There has been Mohit who told us that he will not go for chemotherapy, the immune checkpoint and sacituzumab alone. Mohit, what evidence do you have to support you that data set? Any evidence you have to support not to use chemotherapy and only immune checkpoint and sacituzumab in front line?
No, sir, I think I told by mistake the chemo
Okay,
is a
no issue,
backbone.
no issue, no issues. So Rashmi, Atizo, would you go for Atizo because it was still positive? If you take nab-paclitaxel, time passion 130 did show that it is a positive trial. Although atezolizumab, they pulled back the approval, the Roche did pull back
Exactly.
the approval for this.
Exactly.
Apart from that, science is there. Would you, in a high PDL1, especially and nab-paclitaxel to be a drug of choice for you, would you be still going with Atizo if it is cheaper to you any day?
So as of now, no, sir, until unless I have a good data, because in
That is a
monetary
good
terms
data.
also.
IM Passion, if you look at it, the hazards is looking pretty much as the Keynote 355. It is not different. The only thing the approval is pulled back because 130 and 131 there was a different result altogether. 131 was the negative trial, which used Pacli, and there is a lot of data why this is negative. We won't go into that. So it's okay, you are comfortable with Pembro. I get it. Shaunak, any chance you can give it to Atizo if it's available at half the rate? Cost is cheaper, and you are using nab-paclitaxel.
So then, to open the Pandora's box, then even you have the newer toripalimab and tislelizumab.
Yeah.
Even they have shown within the combination of nab-paclitaxel, there is an OS advantage.
So,
Definitely, sir.
so
Toripalimab
basically
is
the
also
choice.
working like that.
Yeah, so basically the choice of immunotherapy will go forward, but all of us are comfortable with the Pembro at this point. So,
Yes.
so point taken. But yes, if you use a NAP, the IM Passion 130, which you NAP Pacli did show a positive. The 131 which used Pacli was a negative, and then they had to go back to FDA. There was a discussion, and ultimately in 2021, Roche withdrew this approval for reasons well known. Although FDA did agree to continue with the nab-paclitaxel indication actually. So that is the story behind it. So number two, Rajat, if you look at the Pembro approval, it is for PDL1 positive. So do you go for all PDL1 positive to offer Pembro, or do you want to go for a PDL1 high beyond 10 only to offer Pembro?
Sir, I will go for all patients, sir. Yeah.
So you will go for all patients. So I am putting you on the line here. You will go for all patients. I'll show you the data. Okay. Shaunak is smiling. I'll ask him last. Rashmi, for all comers or for high PDL1?
Sir, high PDL1 only.
Okay, high PDL1. You're taking the safe approach, although the approval is for all comers.
Yes, sir,
Mohit?
but I'll go for high PDL1 only.
Okay, no problem. Mohit?
For 10 or more PDL1.
Okay, you will also go for it. Atul? He's traveling. He's still traveling. Okay, we will let Atul travel peacefully. Okay, so what is happening is this data set. And if you look at this data set, if you look at the CPS 1 and beyond, look at the lower part of it, you see that the hazards is 0.86. It is still a 14% benefit, but the confidence interval is wide. And if you look at the top one, which is CPS more than 10, and if you look at it, the hazard is 0.73, much better than all comers or for a CPS more than 1. And if you look at it, the confidence interval is not wide. So technically, most of us believe very strongly that the CPS more than 10 is where it is. And if you look across the scientific data set, all the data sets are pushing for CPS beyond 10 to use pembrolizumab. So this is what it is. You may use it, but I think the data set is more strong for high CPS. Shaunak, agree to this? In your practice, you use
Yes,
it
sir,
only for
agree.
a higher CPS score?
Yes, sir, agree.
Okay. And if you look at this forest plot and look at the CPS more than 1 and less than 1, and look CPS less than 1 and more than 10 and less than 10, you see that 10 is the cutoff where the forest plot looks much more better for CPS 10. Less than 1 and more than 1, you don't find that much of a difference. So basically, it does point out that this data set of triple negatives 355 is more better beneficial for a higher CPS score. This is one thing I feel science is telling us to do. It should be given not to patients who are below 10. Ascent, yeah, anyone wants to speak something? Okay. Ascent 04 is something which two of my panelists took forward. This is a data set put up in ASCO 2025, and this data set looks at the sacituzumab govitecan plus Pembro versus the Pembro plus chemo versus what we see the data set of the triplet. And if you look at it, it was a hierarchical analysis actually. If you looked at PFS positive, then they looked at OS, either interim or final. If the OS was only positive, then only you look at response rate. So mind you, the OS data is negative. So we will not be commenting on response rate, although it was released. But statistically, it was not powered, and hierarchical analysis tells you that once it is a negative, then you do not comment on the next step, what is to be there. So PFS, if you look at it very nicely, it is positive. The hazards looks 0.65. So actually, it met its primary endpoint. The combination of this does benefit, and if you look at it, yes, there is a benefit. And actually, I wanted Mohit to commit, and actually, Mohit, this is what the data set is actually. You are right, actually, but
Sorry. But
you
I,
you just withdrew back just on my questioning. So actually, if you look at it, this is the data set actually, and you were right. This is the data set actually, and I put it in a different way, and people did commit on the other part. So if you look at it, this is the data set.
so
And if you
I
look
thought
at
I
it,
forgot.
no issues, no issues. I just wanted to pull your legs. So if you look at it, the PFS is beneficial for everyone except for if you have used a prior PDL1, it is not to be done. Although only 4 or 5% of the patient in this trial had received prior PDL1, and the OS was immature, but it was numerically better for the combination, but statistically insignificant. Shaunak, would you wait for the OS to mature further? My simple point, because the OS data tells me one thing, 80% received subsequent sacituzumab govitecan, and once you give subsequent sacituzumab govitecan, your benefit of PFS is just going away. So it gives me a confidence that if I miss giving sacituzumab govitecan in front line and I give it in second line, I would not be doing
Losing out on.
any harm to the patient in terms of survival. What is your take on
Yes, sir.
that?
Sir, I agree with that point, sir. But there was one more in the forest plot, that those that were de novo metastatic had lesser benefit.
See, if you look at it, these were not statistical as you spoke last time when we met physically. You do not
Yes, sir.
you look at the forest plot that way, little bit here and there. But look at the prior neoadjuvant, the diamond is only towards this side. That's why I just
Yes, sir.
spoke about it. That's probably the data set which I look very carefully for a prior neoadjuvant immune checkpoint today when we use it. This is not a regimen. We should be avoiding immune checkpoint later on. So that's the only thing which I wanted to put it. Very quickly, last 5 minutes. If it would have been BRCA positive, Rashmi, now
Yes,
this
sir.
patient is BRCA positive.
Sir,
Okay.
if PDL1 is positive, yes, if PDL1 is
PDL1 is
positive,
positive, BRCA is positive. How would you sequence your treatment?
sir, irrespective of BRCA positivity, I'll go for Pembro first. Pembro with chemo first.
Then, if after progression, sacituzumab
After
govitecan.
progression,
Hmm.
like probably depending on like the kind of progression. If it is
Deep,
massive progression,
deep
patient is
finances.
not
I'll give you the
responding
type of
rightly.
progression. I'll give you the type of progression. Don't worry. Deep pockets, very good PS, and the patient has 3 to 5 liver mets progressive disease. Otherwise, maintaining a good PFA, good performance status, and LFT is not compromised. So I hope you have
And
got
how
that
much,
patient right.
like how much DFI patient, like how much,
The
benefit?
patient progressed after 9 months of receiving the chemotherapy plus pembro.
Sir, in this case, if patient has responded well, then secukinumab govitecan. If patient is
Okay.
not responding to ICIs and chemotherapy
So
and
for this
everything,
patient, for you, it is immune checkpoint plus chemo followed by sacituzumab govitecan. Then you will think of BRCA. Then you will think of
yes, sir.
PARP inhibitors. Am I right?
Yes, if
Okay, no,
patient is
fair
yes,
enough.
if patient is
Mohit,
responding well.
what
yes.
is your sequence? Any different?
So I would like to use olaparib on progression.
So you will use immune checkpoint plus pembro and then go for olaparib and then probably go for SASI. That's what you are speaking, Mohit.
Yes, sir. Because
Okay.
for the olaparib, the earlier the better.
Okay, fine. It's a good point. Atul, you are there? No. Okay. Rajat, what is your sequence? You will go with Mohit or you will go to Rashmi?
I will go with Dr. Rashmi, sir. I'll use
Okay.
SD first and then.
You will go with Dr. Rashmi and you want to give olaparib as the third option.
Yeah,
Shaunak, 2 choices. Rashmi
Sir,
or Mohit?
I would go with Dr. Mohit, but I'd also consider adding carboplatin in the chemo, not just a
Because it is a
pembro plus
BRCA
nab-paclitaxel.
positive, you will go for a Pacli, Carbo, and pembrolizumab in the front line.
Yes,
That's
sir.
what you spoke about. And after progression, you want to go with olaparib.
Yes, sir.
Okay. So let me give you the data set. All of you are right, actually. I'll just give you the data set and then you have to choose the best. Shaunak put up a very important point. If you look at it, most of us believe that once a BRCA positive, platinum has to come in some point. And we know that platinum single agent also is a very active drug. Point taken. Point number one. This is something which I put up and taken from the chat GPT. So this is AI generated. So it compares actually very nicely the Olympiad, the Embraca. I'm just going to go to these two. Shaunak, the Brocard, if you look at it, had a Veliparib plus carboplatin as the combination, which is not a very popular choice. And for reasons that toxicity, and if you look at it, the OS was not beneficial. Anyway, OS is not beneficial for any one of it. Just if you look at it, the Olympiad looked at it, Olaparib versus chemo. And if you look at it, it had used patient till up to 3 lines. And if you look at the Embraca till up to 2 lines, the hazards was positive for the PFS, but all the time the OS was negative. So mind you, all the PARP inhibitor, the OS has been negative for all trials. The beautiful point, if you look at the Niraparib, it was a negative trial, even although the Tolaparib, Talazoparib and Olaparib was positive for PFS, Niraparib single agent was negative for PFS even. But the Nira plus Pembro data looks little stronger because there is a synergistic activity of immune checkpoint and the PARP inhibitors. But what I wanted to show is here. It tells you one simple thing, that if you are using Olaparib as your agent, earlier the better. Once you go to 3rd line or 2nd line and beyond, you do not get much of a benefit even on PFS, and OS benefits totally gone. But if you use the Olaparib in the front line, you are actually getting even a significant OS benefit, although the trial was not powered for that. In contrast, Talazoparib is showing their activity irrespective of the lines of therapy. This is again AI generated. And this is actually there in the subgroup analysis, telling with the fact that these trials were not powered. The only small thing which I wanted to use, because Olaparib is the drug which you're going to, Dr. Ajit, it is better to use it 2nd line rather than push it to 3rd line. The toxicities are much more, and sacituzumab govitecan does find its a good activity beyond the 2nd line also. So this is one small thing, but all of you are right actually. There's nothing as a contraindication. Last question before I end. Shaunak, now we have also one more ADC, the DAPO. Now, can you tell me any data set which you would be using a ADC sacituzumab govitecan and then use a DAPO?
So Dato-DXd did not use prior ADC patients in that trial, in the Tropion breast trial. And the OS was also negative with Dato-DXd.
Okay. Anyone has a different answer?
No, sir. I
Okay.
agree with
I'll
Dr.
tell you, go back and read Tropion breast 001. There was a subset of patients. It was 001 was the phase 1 data set. There are 2 types of patients, although numbers are small. One who had not received anything as a topoisomerase inhibitor like a sacituzumab govitecan. One subset had received sacituzumab govitecan. The only difference was, although there was a PFS, but the PFS in the pre-exposed was around 4 months. In the patient who were naive to any topo inhibitors were around 7.5 months. So yes, the data set for ADC followed by ADC, it is there, point number 1. But it is not encouraging. If you're not exposed to sacituzumab, you would be getting a more PFS than compared to if you're exposed to sacituzumab govitecan. So this is where the data stands. The Tropion breast 002, the data is not yet out, which will give us much better answers of what is going to happen in this subgroup. So I'll end here. Chemotherapy plus Pembro, as was spoken. Even if you are PARP positive and you are okay with giving a PARP inhibitor in frontline, that's what small point which I wanted to make. This is actually as per the recent ASCO publication in the ASCO booklet. 2nd line, sacituzumab govitecan has an excellent data set. PARP inhibitor, if you have not given in the front line, you can use it in the 2nd line. Chemotherapy is always an option, that all of us know. Trastuzumab deruxtecan only if HER2 is low, that also all of us know. So this is probably the data set which you're looking at. The Ascent 04, which was spoken in this panel, is not yet approved as of now. But what I mean to say is this is a good combination and it's a chemo-free combination. So this also will be there someday, but the OS data has to mature. Probably if the OS is positive, it is good enough. Otherwise, it gives us an idea that if I'm not given sacituzumab frontline and I can give it in 2nd line, I'm not compromising on the OS. Any final comments from the panel?
No, sir. Thank you so much.
Thank you. So if that
Thank
is
you, sir.
it, so I'll stop here and hand it back to the organizers, and I'll stop sharing. And I hope something has been added to the knowledge of people who are there in this online meeting. Thank you.
Definitely, sir. Thank you. Thank you so much.
Thank you,
all.
Sahu sir, for joining us, and it is always a pleasure to listen you. The flow you make, and always pleasure to listen you. I've been listening to you since I was in Bhopal, and I miss Bhopal. That's why listening to you, Shaunak sir. Thank you for joining us, all the panelists, Dr. Sahu. Now moving on to the next session. I would like to welcome Dr. Farheen Khan, and she's a surgical oncologist at Manipal Hospital, breast surgical oncologist, and she will be speaking on role of de-escalation in axillary surgery in breast cancer. Dr. Farheen is here. Thank you, Dr. Farheen, for joining us.
Hi, Abhinav. Thank you. Am I audible?
Yes, ma'am, you're clearly audible. Thank you for joining us. We
Right.
can proceed.
Sure.
Ma'am, if you can just share your video and
Sure. I'm just trying to figure out where exactly should I. Okay. Got it. Yeah.
yes.
So, very good evening to all, and thank you for this opportunity. So, here is an important topic that we are dealing with nowadays. It's the de-escalation in axillary surgery, and why is it so important? So, as we all know, axillary status in breast cancer is one of the most powerful predictors of survival. And this knowledge has plays an important fundamental. It gives us important fundamental information for making multidisciplinary plans for the patients in all stages of cancer. However, from 1990s, ALNDs have been kind of getting replaced slowly and eventually by sentinel lymph node biopsies, though there have been a lot of discrepancies in the data, and we do not have very conclusive data still for some stages of cancer. However, sentinel lymph node biopsy focuses removal of only certain axillary nodal basins without removing all the axillary tissue, and hence decreasing the morbidity in terms of lymphedema, chronic pain that the patient suffers. So management has further evolved over the years, and such that the decision of doing sentinel lymph node biopsies in all stages of invasive breast cancer, and the imperative to follow up with an axillary lymph node dissection in patients who have positive sentinel lymph node biopsies have been questioned. Also because of the advent of targeted therapies and very good chemotherapeutic agents, we have good outcomes. We have complete pathological responses, and that has actually brings us to a question that why should we completely subject a patient for axillary dissection? So in some aspects, this point has been confirmed in certain stages. In certain stages, still the issue is contentious. So moving on, sentinel lymph node biopsy is the standard of care for early breast cancers undergoing primary surgeries. But contentious issues is in post-NACT management of axilla in early breast cancer, where N0 becomes N0, N1 becomes N0, where I'll be discussing about role of targeted axillary dissection. Then N1 remains N1. The next issue is post-NACT management of axilla in LABC, where we deal with tumors T3 with N0, N1, which become N0 after neoadjuvant chemo, and T4 and N2, N3 clinical disease, where the nodal disease becomes N0. That is the complete pathological axillary response. So here the problem in post NACT is with the fibrosis that happens blocking the lymphatics. That is one hypothesis that a lot of people discuss, that the sentinel lymph node may not be reached. The nodes which appear as blue or hot may not be actually the representative sentinel lymph node. Second is with neoadjuvant chemotherapy, not all the actual sentinel lymph node may not shrink evenly, as in uniformly throughout the axilla. So what we pick up may not be the actual lymph node basin of the drainage. So that doesn't, downstaging of sentinel lymph node doesn't mean downstaging of axilla. That is one point of discussion. The third point to be discussed is post-NACT management of axilla in patients with limited pathological N1, like one node positive or two nodes positive, or microscopic disease only, or isolated tumor cells, which can be picked up only with IHCs. So can completion ALND be avoided safely in such patients? So neoadjuvant chemotherapy is very effective strategy in breast cancer, and progressively increasingly its applicability is being seen in LABC and LOBC, even in early breast cancer with bad biology like triple negative cancers and HER2 positive patients. So these are the patients who receive pathological complete response, and this is of prognostic importance. So with NACT, what happens is the surgery is lesser, it is kinder, and it becomes more effective in patients with overall survival and low rate of recurrence. So there have been multiple multicentric prospective trials based on initial studies starting from Almanac. And so these showed that in the primary surgical setting, the identification rate, that is the IR, for sentinel lymph nodes were up to 90% with a false negative rate of 10%. So for a good yield of sentinel lymph nodes, we want good identification rate and we want a very low false negative rate. So we can perhaps extrapolate this primary standard to post-neoadjuvant setting too. So in post-NACT SLNB, the contentious issue that we are going to discuss is management of these 3 points. So is SLNB after NACT appropriate? So data from prospective trials, as I've already mentioned, is good. There are a good identification rate with a low false negative rate if dual tracers are used and 3 or more sentinel lymph nodes are excised. The technique is very important. So these are a few of the trials which I would like to discuss. ACO-SOG Z1071 trial, which had 756 patients. And the patient population was T0 to T4 with N1, 2 staging. Their SLN identification rate was in the tune of 92.9%, with overall false negative rate was 12.6. So this false negative rate of 12.6 comes because of the locally advanced cancers that are included in this. At the same time, Sentina has 4 arms, out of which the third arm is where N1 nodes become N0. And this is the arm which has 592 patients. Their sentinel lymph node identification rate was 80% with a higher false negative rate. SN-FNAC trial from America had single arm, 153 patients. Their identification rate was around 87%, and so were the identification rates from the French studies. What they have included in ACO-SOG and SN-FNAC are presence of microscopic deposits, which can be found only in the pathological final histopathological reports. And it was reported that that SLNBs with microscopic isolated tumor cells may not be subjected to ALNDs further, and radiation can be done later. So based on this NCCN guidelines, so this is the part which is most important in this table, where an FNA or a co-biopsy is done in the preoperative pre-chemotherapy setting. If patient does not undergo chemotherapy, preoperative chemotherapy in N1 axilla, we upfront do a surgery and do ALND. But if patient receives preoperative chemotherapy and patient on post neoadjuvant chemotherapy assessment node is still positive, as in the clinical assessment nodes are present, we straight away go and do ALND. But if the N plus gets converted to node negative, then the patient can safely undergo SLNB. This is the standard guideline and in clinical practice. So when a clinically node positive becomes node negative is actually where there is more problem in discussion. There is no proper guideline where the role of targeted axillary dissection comes. So here is where in pre-NACT setting where the node axilla is positive and the patient is planned for NACT, one should undergo ultrasound guided co-biopsy and clipping. Other alternatives are somehow you have to mark the node with carbon tattooing, iodine 123 seeds, or super magnetic iron oxide, which stay for 30 days. So post NACT, if the axilla is N0, SLNB plus targeted removal of all the clips can be done. This reduces false negative rate by half and reported to reduce local recurrence rate. So there are trials underway for this, and they have found significantly low false negative rates in such cases of targeted axillary dissection. So these are certain published trials and studies from all around the world, which says that the clinical feasibility and the safe oncologic outcome with targeted axillary dissection is comparable to doing an axillary dissection with reduced morbidity. So recently updated German Gynecological Oncology Group guidelines say first to list, they are the first ones to list targeted axillary dissection as standard of care for N plus converted to N0 post systemic therapy. So whether the question here that is posed is whether a targeted axillary dissection would be considered in N plus turn to N0 patient after NAST or not. So this they conduct the EU breast survey was a web-based survey with 349 breast surgeons in 45 countries, and this is their experience. So targeted axillary dissection was done by 54.2% of the patients, and SLNB alone was done by 20.9% of the patients. Level 1 to 2 ALND was done by 18.4% of the patients. Level 1 to 3 ALND was done by 4%, and targeted lymph node biopsies only in 2.5%. So YC N plus tumors, ALND was still the preferred surgical approach for 66.8% of the surgeons. So universal applicability in questions due to technical complexity. So for performing an SLNB and a targeted lymph node dissection, we need good radiologists to clip the node or a nuclear medicine backup. So there is a lot of technical glitch in this, and there's a lot of technical so a lot of technical complexity comes in targeted axillary dissections. So this is Oncoplastic Breast Consortium, where omission of axillary dissection following nodal downstaging with neoadjuvant chemotherapy was discussed. The study showed 1144 patients with N1, N2, N3 disease, which became N0 after that. So here SLNB versus targeted axillary dissection was done. 666 sentinel lymph node biopsy with dual tracer mapping, plus 3 or more sentinel lymph nodes were removed, and 478 patients underwent targeted axillary dissection. So basically in this paper, there was no significant difference between axillary recurrences between the two arms. at 3 years, confirming that in short-term follow-up, both techniques were oncologically equivalent, provided we have good technique in place and the nodes have been targeted well. So this is one ongoing non-randomized observational trial, which will be completed soon. By September 30th, 2024, 5,881 patients were enrolled. And they are essentially comparing the outcomes in node positive patients post NACT. So there are these 3 set of patients who will either undergo targeted axillary dissection or SLNB versus targeted lymph node biopsy versus ALND. And this will provide prospective data on invasive disease-free survival and axillary recurrence. So post-NACT management, so till now we have discussed about post-NACT management in early breast cancer. So only one contentious issue in the above is N1 remaining N1. Now coming to post-NACT management in LABC. So here we deal with tumors which are T3, N0, N1, which become N0, where SLNB seems acceptable. Whereas in T4, N2, N3, SLNB does not seem to be acceptable, even if the axilla has turned N0. So there are these 2 studies from India which were published, where they dealt with tumors, locally advanced breast cancers with T3 and T4 tumors and N1, N2 axilla, where their identification rate was up to 100% for sentinel lymph node biopsies. And their sensitivity was 86.6% and accuracy was 93%, which is acceptable, but still axillary dissection cannot be not be done in cases of locally advanced breast cancer. So the data in SLNB in LABC is not well established as in early breast cancer because of high false negative rates that occur in T4 and T3 diseases. So while we extrapolate the data of primary surgery to post-NACT early breast cancer, we cannot extrapolate that data to locally advanced breast cancers. So there is limited data in prospective studies. And some of the trials like Sentina and Alliance have 5% and 25% of locally advanced and locally large operable breast cancers, but they do not favor sentinel lymph node biopsies in LABC, especially in T4 diseases. So this is a study done at SGPGI and was published in 2016. What they have seen, their results are that the role of the identification rate in early breast cancer and locally advanced breast cancer of sentinel lymph node biopsy is comparable. But even though this data is comparable, they found that avoiding axillary dissection just by completing the surgery with sentinel lymph node biopsies did not give good results, and they had to do a completion ALND. So post-NACT management of axilla in patients with limited pathological N1, microscopic and isolated tumor cells, can completion ALND be avoided safely? So the answer to this could be yes. So in this case, there are 2 studies which are ongoing. That is Alliance randomized control phase 3 trial evaluating the role of axillary lymph node dissection in breast who have positive sentinel lymph node disease after neoadjuvant chemotherapy, and tailored axillary surgery with or without axillary lymph node dissection followed by radiotherapy in patients. So here there is a scope that it could be done, but definitely not in T4 disease because of the biology of the disease. So outside of clinical trial, when we talk about practice, actually ALND remains the standard of care in residual disease and SLN post systemic therapy. Whereas management of isolated tumor cells in multicenter study, ICARO study, T1 to T3, N0 to N3 disease underwent NACT, and ITCs were detected in SLN either by H&E staining or IHC. So out of 583 patients, 182 underwent ALND and 401 did not undergo any ALND. So among ALND patients, 30% had additional positive notes on final histopath, 18% had only additional ITC, 7% had micromets, and 5% had macromets. So ALND versus without ALND, there was no difference in 5-year axillary recurrence and invasive recurrence, which was only 16% in ALND and 19% in no ALND. So here findings suggest a very low likelihood of clinically significant residual nodal burden among those with ITCs after NACT, and do not support routine ALND in this setting. So we can probably escape just by doing selective dissection in cases where ITCs are possibly present, but this happens only on final histopathology. So you do a limited resection, you take that risk, and then you wait for the results. So in summary, post NACT management of axilla, what is most essential is the staging and loco-regional control. ALND remains the standard of care for most. Pre-NACT SLNB or post-NACT SLNB is an option in selected groups only. So T0 to T3, N0 to N1 to begin with, and definitely not for T4, N2 patients and above. 3 is also a stretch here, I would say, but there are studies in support of it. In clinical practice, still with T3 disease, it would be difficult to just settle with the SLNB in a locally advanced breast cancer, especially when patient had N1 disease. That is my personal opinion on the matter. So high identification rate and low false negative rate can be achieved by dual tracer technique. So minimum at least methylene blue and technetium 99 or ICG should be used. More than or 2 sentinel lymph nodes should be removed. IHC for detection of ITCs is preferable, and targeted axillary sampling and dissection of pre-NACT N1 nodes should be done if already marked. So ALND is must for patients with any metastatic sentinel lymph nodes, that is a cutoff of 2 or more, and RT decisions are made in the pre-NACT staging. Post-NACT management is when index stage was N0, post-NACT is N0, can go ahead with the SLNB before or after NACT, and ALND if sentinel lymph nodes are positive on your dissection. Post-NACT, even if single node is positive, you should go ahead with completion ALND and adjuvant RT if pathological N1 or any worse staging. If it was already N1 and it has become N0, here is the point where you should do SLNB or focused axillary sampling, followed by ALND if there are any lymph nodes which are positive on sentinel lymph nodes, and adjuvant RT. So if the axilla was N1 clinically and post-neoadjuvant, it still remains N1.
I'm sorry for interrupt you. Can you conclude your talk in 1
Yeah,
or 2 minutes?
Yeah, it's my last slide almost. Just 2 more slides. ALND and adjuvant slide, adjuvant RT, and N2, N3, any stage, ALND and adjuvant RT. So post-NACT SLNB is not as well established as primary surgical SLNB. We have already discussed the contentious issues. So de-escalation of axillary surgery for post-NACT, are we really ready? Yes, for T1 to T3, N0 to N1, which become N0, yes. And no for T4 and N2 disease. Thank you.
Thank you, Dr. Fareen, for an illustrative talk on, this is something which we medical oncologists require to know, because, always we keep on talking about different newer drugs, but de-escalation of axillary surgery, because we all know that after the axillary surgery, the side effects, the lymphedema and everything, these are the long-term side effects of these surgeries. So yes, we are moving towards a de-escalation of axillary surgeries. As you told, for N1, yes. and let's see. But I think we are not yet ready for still you only told that ALND still remains the standard of care.
Standard of care where it is still an N1 axilla after neoadjuvant chemotherapy.
Neoadjuvant.
Or it was an N1 or N2 to begin with, or it was a locally advanced. So clinical practice is obviously a little different from what comes from the trials. It has to
And
be
we have been using in our hospital, sentinel lymph node. We have been using, and it has become a standard of practice for us.
Yeah, absolutely. Yeah.
So thank you, Dr. Farid, for joining us and giving such a wonderful talk. Now moving on to the next
Thank you.
topic, I would like to welcome Dr. Ishu Gupta, who is a medical oncologist at Amerix Cancer Center and a very dear friend. And he will be speaking on role of Phesgo in metastatic HER2 positive breast cancer. Thank you, Dr. Ishu, for joining here.
Hi, good evening. Give me 1 second, please. Video. So why is it? Yeah. Hi, good evening. Thank you, organizers, for having me here, and thank you, Roche, for providing the slides. I know we are in 2025 and we are discussing Phesgo, where ASCO is discussing Destiny Breast 09, that deruxtecan become the first line, and it probably can. However, as of today, when we talk about the first line treatment in this, Cleopatra still remains the standard of care. So let me just start with the situation all of us have seen in the clinic somewhere or the other. 41-year-old female diagnosed with LABC, was seen by a surgeon previously, operated upfront, and we had no choice but offer patient adjuvant therapy. This patient was offered epirubicin cyclophosphamide followed by paclitaxel and maintenance therapy and radiation. She had a PT2N3 disease, ER negative, PR negative, and HER2 positive disease. In the given situation, most things done right. But then, unfortunately, after a year, she starts developing symptoms like back pain, abdominal pain, weight loss, and as rightly ordered and as expected, the PET reveals a widely metastatic disease. Rebiopsy done again shows a HER2 positive disease, still, which is ER/PR negative. The patient in Jan 2024 was started on a Phesgo, a fixed dose subcutaneous combination of trastuzumab, pertuzumab, along with docetaxel and denosumab because of the bone mets. After 1 cycle, the patient was almost asymptomatic, and after 3 cycles, the PET done was suggestive of a CR. A near CR, I would say. And the patient's PS also obviously improved with this. In December 2024, about a year later, the patient was on maintenance Trastuzumab plus pertuzumab and continued to be disease-free. So this data comes from the backbone of the Cleopatra trial, which is still the first-line therapy, as I mentioned, in HER2-positive MBC. Trastuzumab, when pertuzumab is added to trastuzumab, it complements the action of trastuzumab by blocking the dimerization of the HER2 molecule and activating the antibody-dependent cellular cytotoxicity. Both of them, though, have slightly different mechanisms, but they are complementary to each other and hence have been demonstrated in the Cleopatra trial to be very efficacious together. Cleopatra was the trial which showed efficacy of these molecules in first line as the standard of care, which were initially given by IV and then later on shown that subcutaneous fixed dose combination was also a very good option there. So coming over to the trial itself, it had many data sets. With the last data set that had come in was the final OS analysis that was November 2018. Patients were metastatic HER2 positive cancers, which were obviously centrally confirmed, and these patients were randomized to trastuzumab plus docetaxel versus trastuzumab, pertu, and docetaxel. Primary endpoint being PFS, secondary endpoint being safety, OS, PFS, ORR. The baseline characteristics were more or less balanced in both the subgroups. And when we saw that the PFS was 18.5 months in the combination arm of trastuzumab compared to a 12.4 months of PFS in the trastuzumab only arm. Also important to point out here is that the 8-year landmark PFS that we had in 2018 was 16%. So 16% patients were still disease-free in the combination arm versus 10% patients from the trastuzumab arm. One second, I think we missed the OS. Yes, the OS that came out in the end, that is the latest data that we have, is 57 months of OS from the combination arm versus 40 months with an impressive hazards ratio of 0.069. And at the end of 8 years, we have 37% patients being being alive in the combination arm versus 23% patients in the trastuzumab arm. The side effects more or less were manageable with some diarrhea, sometimes, yes, being bothering, especially initially, but later on usually settles down, manageable. Sometimes you might have some extra fatigue or rash, but otherwise more or less manageable side effects. So the safety profile is, yes, consistent and manageable, not really concerning apart from, as I mentioned, diarrhea and sometimes fatigue. And so we have 56 versus 40 months when we combined pertuzumab in the trastuzumab and docetaxel of overall survival, and 12.4 months in the of PFS in trastuzumab docetaxel versus 18.5 months in the docetaxel trastuzumab and the pertuzumab. When this data was analyzed by ESMO also, and how much was the clinical benefit on the scale, it came out that when it was balanced with the toxicity also, it came out to be a very impressive scale of 4, which is usually one of the maximum scores that we are able to attain. And hence, it was established that IV infusion of Perjeta Herceptin was a well-established treatment. However, even after such an impressive, data and long-term use of Perjeta and Herceptin, this required long infusion and observation times. The hospital was, the chair and the bed was blocked for a long time, and a venous access was required for a long time. Sometimes you might have to reinsert a port or something. So, as you say that sometimes the biggest revolutions don't come by a new molecule, they are by a new PFS itself. So Phesgo was the first formulation which revolutionized this treatment. And it was a fixed dose syringe which was replacing the IV pertuzumab as well as trastuzumab, both of them. The loading dose was a 15 ml dose with a maintenance dose being a 10 ml dose, could be administered over 5 to 8 minutes. So what trials showed that Phesgo was non-inferior to IV Perjeta and Herceptin? Basically, the Federica trial said that it was non-inferior. When in a locally advanced HER2-positive cancers, IV treatments were head-to-head tried against fixed dose Phesgo, with the primary endpoint being non-inferiority of the 7th cycle. And the number of patients landing up in the PCR. So we saw that pharmacokinetically, the concentration of pertuzumab as well as trastuzumab that was achieved was very similar in both the IV as well as the subcut formulation. And also the percentage of patients achieving a PCR was very similar in both, about 59%. And a trial within which the primary endpoint was the patient preference rather than anything else. So it was seen that 85% of the patients preferred fixed dose subcutaneous formulation versus an IV formulation. Patients were more satisfied, 88% versus 14% with a subcutaneous formulation. And safety was manageable and comparable in both the arms. And the Fatima trial, that was very, very important, especially for the hospitals rather than the clinicians, that said that you could give the same treatment in less time with the utilization of less resources. So Fatima trial said that mean time spent per cycle per patient was reduced by a significant of 120 minutes. The chair time or the room time was reduced by at least 2 hours per patient. And the time required for drug preparation, administration, and in total of both significantly reduced compared to 46 minutes or 47 minutes for IV versus 23-24 minutes for a subcutaneous preparation. So, and also the wastage of the materials, the consumables used when giving the drugs was significantly reduced. And this was very well demonstrated in this Fatima trial. So it was very well established that this is a revolutionary drug, and we have been using it for the last few years. And I think all of us would agree to it that it is a wonderful drug, easy to administer, and when patients are mostly happy with it. So the pharmacist is happy, the cancer specialist is happy, the hospital is happy, and the patients are happy. And that's what this drug has done to this subset of patients. Thank you, everybody. Most welcome to take any questions.
Thank you, sir, for a wonderful talk on Phesgo. And really, Phesgo, has made us work easy. I would just like to, are you using Phesgo in your OPD practice, or still you admit the patient for daycare admission?
Phesgo, we
Leaving
sometimes,
apart the insurance thing.
insurances do kind of mandate that the patient needs
Daycare
admission. So you cannot just give it off in OPD. We are admitting them to a daycare, but the discharge is very fast. It usually happens in 30 minutes and the patient is off.
No, so if the patient is not a insured patient, not using insurance, are you using, any one of us is using in OPD practice? Like, come
Still
to
not
the
doing it in OPD just because of certain medical legal sometimes that can pop up. Very, very rare you can see a hypersensitivity reaction. Although I have not seen it in last few years, but still it is documented. So given that, we always tend to admit them in daycare at least.
Okay. Okay. Thank you, sir. Thank you. Thank you so much for joining us. So
Thank you, Dr. Abhinav.
as we proceed forward, I would like to welcome Dr. Abhishek Raj, who is a consultant medical oncologist at Sarvodaya Hospital, Faridabad. He will be speaking on some of the abstracts on breast cancer recently presented in ASCO 2025. Thank you, sir, for joining us, welcoming you here on this webinar.
Thank you. Thank you, Dr. Abhinav. Thank you for a warm introduction. And I think I've chosen 3 abstracts. One of them is also mirroring what Dr. Ishu was saying. It's on Destiny Breast 09, some of the very early results. But let's start with this camizestrant. We know we have come a long way with fulvestrant. I've got a lot of slides, so I'll quickly skip through. So basically, I hope my slides are visible. Yeah.
Yes, sir.
So I think we'll learn about the key takeaways afterwards. So just coming to the background. So we know that 70% of the breast cancers are hormone receptor positive, and ESR1 mutation is one of the resistance pathway of resistance mechanism to your hormonal therapy. At the time of diagnosis, de novo ESR1 mutation are very, very rare. And when the patients are treated with AI plus CDK4/6 inhibitor, it is one of the most common pathways of resistance to endocrine therapy. So it can be seen in almost around 40% of the patients at disease progression. So this new drug, camizestrant, it is a next generation oral SERD and a complete ER agonist. It is designed to inhibit and degrade the mutant as well as the wild type ER. So that is why it is slightly superior to the drug that is already available to us, which is fulvestrant. So what is the background to this study, this SERENA-6 study? So ESR1 mutation is something that can be detected in liquid biopsy. There was an initial PADA1 trial where switching to fulvestrant plus palbociclib upon detection of ESR1 mutation ahead of disease progression, it significantly improved PFS versus continuing the same treatment. In the SERENA-2 study, this camizestrant, it significantly improved PFS versus fulvestrant in pretreated ER positive AVCs, including in patients with ESR1 mutant patients. So this hypothesized that maybe we can preempt the development of this mutation once the mutation develops, even before clinical progression. If we can initiate the drug can it lead to improvement in the outcome? So we'll discuss that. So this was a surveillance for ESR1 mutation that was done when patients were treated with first-line AI plus CDK4/6 inhibitors. They screened around 3,300 patients. These patients underwent every 2 to 3 months ESR1 mutation surveillance using Guardant 360 companion diagnostics. And then the patients detected with ESR1 mutation was around 548 patients. So you can see around 1/6 of the patients were detected to have this mutation while they were on therapy. Among these, 51% patient had positivity on the first test, and then another 38% had after 2 to 5 tests, and only 11% of the patient had positivity after more than 5 tests. And among these, 315 patients were randomized. There were some screen failure patients because these patients had concurrent disease progression. So if the patient had clinical progression of the disease, they did not receive this drug. And if patients were not meeting other eligibility criteria, or there were some patients where reason was not provided. So this is the randomized control study. That was a double-blind placebo-controlled study, which included patients with ER-positive, HER2-negative advanced breast cancer patients. All patients were treated with first-line AI plus CDK4/6. All the 3 CDK4/6 inhibitor patients were included as the initial endocrine-based therapy, and they have to have received this therapy for at least 6 months with ESR1 mutation detected in ctDNA without any evidence of progression of disease on imaging. So they were randomized to camizestrant 75 mg every day plus continuation of CDK4 inhibitors plus placebo, as compared to continuing AI plus CDK4/6 inhibitors plus placebo for camizestrant. So it's a double placebo. In the other arm, they have used placebo for AI because once they detected the mutation, they switched the AI to camizestrant. These were the stratification factor as they were mentioned. PFS was the primary endpoint. Quickly coming to the baseline characteristics, as you can see here, majority of the patients were very well matched. And you can see that this we've discussed the timing of ESR1 mutation. If we talk about majority of the patients, 3/4 of the patients were treated with palbociclib as the CDK4 inhibitor, and visceral metastasis was present in around 40% of the patient. And these are some of the mutation subtypes that they have detected. As you can see here, the investigator assessed PFS was 16 months after the detection of after randomization as compared to continuation of the same therapy. So as compared to mechanistically, I think this makes sense that if the mutation has come up, eventually if some patient is these patients are going to relapse, but we need to have a hardcore clinical data before we can utilize in our clinical practice. So rather than initiating this drug at the time of progression and detecting that, okay, this mutation has been present, and then you initiate this drug, because we know that there are a lot of patients who fail therapy after first line progression. So if you're monitoring it and you are preemptively starting the treatment, it leads to improvement in the PFS with a hazard ratio 0.44, which is excellent. If you see the subgroups, majority of the subgroups have shown benefit, and this magnitude of benefit is really amazing. The hazard ratios are good, and it is all favoring camizestrant, irrespective of visceral metastasis or not, what was the companion CDK4 inhibitors, what was the timing of ESR1 mutation detection, irrespective of the type of the ESR1 mutation. So whatever it is, all the subgroups are benefit. If we talk about the PFS2, so initiating this therapy early, it is also leading to improvement in the PFS second. So you can see here that the PFS2 is the number of PFS2 events are 38 on a longer follow-up versus more PFS2 events have happened in the other arm, which is also hazard ratio is 0.52. So it leads to decrease in the number of PFS2 events as well. Coming to the safety summary, I think relatively, if you look at this, relatively easy drug to tolerate. I think majority of the side effects will be probably attributed to the CDK4 inhibitors rather than this drug itself. But you can see here, we are able to maintain a 99% dose drug intensity, which is really unheard of. So relatively fairly well tolerated drug. Majority of the side effects, as I mentioned before, are probably related to the CDK4 inhibitors, which is neutropenia, anemia, leukopenia. The other side effects are rare. Grade 3-4 side effects are barely seen in the camizestrant arm. So coming to the conclusion, switching AI to camizestrant with continuation of CDK4/6 inhibitor guided by the emergence of ESR1 mutation during first-line therapy ahead of clinical or radiological disease progression, it improves PFS in such patients. PFS benefit was consistent across the CDK4/6 inhibitor and relevant subgroups. Relatively well manageable drug, good quality of life was maintained. the OS data will remain to be seen because I fairly understand that some of the patients who are treated with AI at the time of clinical disease progression will go on to receive camizestrant who are having ESR1 mutation. So it remains to be seen in that subgroup that patients who are harboring ESR1 mutation, where in those patients it is leading to meaningful improvement in the overall survival or not. So the idea is when to use this drug at the time of you preempt the therapy by doing a liquid biopsy, or you treat it at the time of progression and you have detected ESR1 mutation. So I think with a longer follow-up, we'll be able to answer this question. But at this point, it is an interesting study that has been presented. So this also led to the article in NEJM. So moving on, I think we'll discuss about triple negative breast cancer from hormone receptor positive. So sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembrolizumab in patients with untreated PD-L1 positive metastatic TNBC. So this is something I think a lot has been talked about both the drugs. I'll again skip the takeaway that most of the ASCO slides are provided in the beginning. So what is the unmet need in patients who are PD-L1 positive metastatic TNBC? We know that these are difficult to treat patients. We do have approval for, we did have approval for atezolizumab, then we have approval for pembrolizumab in PD-L1 positive subsets. But even those patients eventually have a PFS of anywhere around 8 to 9 months, and then they progress. We know that sacituzumab govitecan is an approved line of therapy as a second line therapy in triple negative breast cancer. Even in ER receptor positive patients, it can be used after the patient has progressed on the previous lines of treatment. So this is a drug. We know that it's an antibody drug conjugate which is directed against TROP2. It has demonstrated OS benefit in various subsets. So it was quite logical and reasonable to combine these two drugs, which have a different mechanism of action, and they do not have significant overlapping toxicities as well. So based on that, I think they have designed this study. So they have included previously treated advanced TNBC patients who are PD-L1 positive, detected to have CPS 10 or more than 10 by the 22C3 assay, and they had to have at least 6 months, which has passed when they were treated with a curative intent setting. So at least they must have had relapse after 6 months. And adjuvant pembrolizumab, if it was used, neoadjuvant plus adjuvant pembrolizumab, if it was used, that is allowed in the study. So they were randomized to sacituzumab govitecan plus pembro, the standard dosing of 10 mg per kg day 1 and day 8 of 21-day cycle with pembro 200 mg, and chemo plus pembro. As we have seen in other studies, it was either paclitaxel, nab-paclitaxel, or gemcarbo in combination with pembro. So this is quite standard treatment that we use for PD-L1 positive patients upfront in our clinical practice. And the primary endpoint was independent committee review assessed PFS or OS, the secondary endpoint. So this is the baseline characteristics. Not going to go into much detail, but as you can see here, this is fairly common, and for all the TNBC subsets, the site of metastasis, what was the chemo backbone that was used, and it is fairly well matched in two population. If you look at the PFS, you can see that the median PFS was 11.2 months in favor of Trodelvy plus pembrolizumab as compared to just 7.8 months for your standard chemo plus pembro, which is mirroring the data that is available for us for metastatic TNBC. The hazard ratio, it is showing that there is a 35% reduction in the risk of progression or death, with a 12-month PFS rate of 48% versus 33%, an absolute difference of 33%. If you look by investigator assessment also, I think it is quite similar to what we see for the independent review committee. If we look at the subgroup analysis of progression-free survival, I think the patients who have received prior neoadjuvant anti-PD-L1 therapy, there the hazard ratio is around 1 with a very, very long confidence interval, but that is probably because of very less number of patients that were treated with adjuvant pembrolizumab. Apart from that, the benefit is seen in almost all the subgroups that were previously defined. And if we talk about the overall survival, it is not yet mature, although we can see that after a long follow-up, even though it is not reached in both the arms, but the number of events are slightly lesser in the SG plus pembro arm. And there is some trend of benefit, but the longer follow-up remains to be seen, considering that the patients who are treated with pembro plus chemo, they can be exposed to sacituzumab govitecan at the time of progression. And the longer term follow-up of OS data remains to be seen. I think TNBC is a fairly bad disease. So I think we'll be getting the answer to this OS data also quite soon. In probably 2 years down the line in the ASCO, we might have a presentation again. If we talk about the responses, the response rates are 7% superior to for in combination for Trodelvy plus Pembro. Median duration of response is also superior. So you can see here that is something which is mirroring the benefit in the PFS, that the patients who do respond, they continue to respond for a slightly longer time. So we talk about the safety summary. Side effects leading to treatment discontinuation is only seen in 12% of patients as compared to 31% of the patients, probably because of the chemo. And grade 3 or adverse events were similar in both the arms. If we talk about the common adverse events, these are fairly similar, as you can see. Neutropenia, fatigue, nausea, diarrhea, anemia, all of these are side effects because of the chemotherapy, as well as the special adverse events are related to the Trodelvy. We know about neutropenia, hypersensitivity, diarrhea, or infections. These are, as you can see here, that the grade 3 or higher adverse events are much lesser. Neutropenia is, yes, common, but that is also there in the chemo plus Pembro arm. Immune-related adverse events, I'll skip. I think it is similar to what has been seen in the previous trial. So this is the first randomized phase 3 study to evaluate the efficacy and safety of a combination of ADC with checkpoint inhibitors as the first-line treatment for PD-L1 positive triple-negative breast cancer. Led to statistically significant as well as clinically meaningful improvement in PFS as compared to the existing standard of care, which is chemo plus Pembro. And it was the benefit was observed in all pre-specified subgroup, although one of the key groups is underrepresented here because now fairly most of us in the curative setting are using pembrolizumab. So it remains to be seen whether this combination will work that great for patients who have been treated with neoadjuvant and adjuvant pembrolizumab. So that is an answer which this trial probably does not answer because those population are underrepresented. ORR was higher and responses were probably more durable with combination as compared to chemo plus Pembro. Safety profile, well manageable, no new safety signals were identified, and the side effects, I think most of us are now well versed with how to manage the side effect. Now coming to the big elephant in the room, it is, I've talked about ER positive, then TNBC, now coming to the HER2 positive breast cancer. I think everybody is awaiting the result of Destiny Breast 09. Everybody wants to use trastuzumab deruxtecan as early as they can. We have seen how wonderful responses it leads to even in the later lines of therapy. That is how now it has moved to the second line of treatment, and probably it might move to first line treatment as well based on some of the results. But as we have seen before, we have to tread carefully. Again, key takeaways in the end, you will all come to know about the key takeaways. So this is how the TDXD has evolved in HER2 positive advanced metastatic breast cancer. This is in the third line and beyond. We have had data for Destiny Breast 02. We have had data for Destiny Breast 01, which is phase 2 and phase 3 data, which has shown improvement as compared to physician choice chemotherapy. In the phase 3 trial, we have Destiny Breast 03, which also shows a marked improvement over TDM1, which is 28.8 months versus 6.8 months when it is used in the second line, leading to its approval in the widespread approval in the second line therapy after patient has progressed on the first line pertuzumab trastuzumab based regime. And now we have data comparing it to the Cleopatra-like regime. So why people are trying to bring this ADC in the first line? Because it's such a wonderful drug. People want to use it as soon as possible because there is always a problem of attrition of patient when the patient progresses on the first line treatment. So it has included HER2 positive advanced breast cancer patients with asymptomatic. They have included brain mets which were asymptomatic or inactive. DFI of more than 6 months from last chemotherapy or HER2 targeted therapy in neoadjuvant setting was allowed. One prior line of ET for triple positive patients was allowed. No other prior systemic treatment for MBC has been taken care of. So they were randomized to 3 arms, TDXD plus placebo, TDXD plus pertuzumab, and the standard of care, Cleopatra THP. And the primary endpoint was PFS. At this interim analysis, which is the data cutoff time of February 26 of this year, results are reported only for these 2 highlighted arms, TDXD plus pertuzumab versus THP. So this was the statistical analysis. So at this cutoff point, the interim analysis criterion for superiority, which is p-value of this, was already met for TDXD plus pertuzumab versus THP. That is why they led to early presentation in ASCO. TDXD plus placebo remains blinded only until final PFS analysis per protocol has been done. First interim OS analysis they had defined at the time of 16% of total that they have expected. Final analysis will be conducted as per protocol. So this is the study schema. They screened around 1700 patients and they ended up randomizing around 1157 patients, equally randomized to TDXD plus pertuzumab, THP or TDXD plus placebo. And the final PFS, so that arm is blinded until the final PFS analysis. As you can see here, what are the reasons for discontinuation? The most common is progressive disease. Then we have adverse events, which is higher in the TDXD arm. As you can see here, it is generally not because of the dual HER2. Baseline characteristics for the two groups which have been which are not blinded to PFS yet. They are presented here. As you can see here, the HER2 scoring majority of the patients are IHC3+. They are fairly well balanced in two arms. Almost 50% of the patients are HR positive and HR negative are the rest of the patients. They have also talked about the number of brain metastasis patients that were included that were also well matched, although they are less than 10%. And visceral metastasis was present in majority of the patients at baseline. So these are the prior treatments that the patients have received. As you can see, fair bit of patients have received trastuzumab. Pertuzumab was received in 8% and 6% in the two arms in the neoadjuvant or adjuvant setting, and very few patients have received CDK4 inhibitors. So if we talk about the coming to the primary endpoint, PFS by independent review committee, median PFS was 40.7 months versus 26.9 months with a hazard ratio of 0.56. If we talk about the PFS rate at 2 years, you can see it is 70% versus 52%. So absolutely clinically meaningful 18% benefit in 2-year PFS rate, which is quite significant. Absolute benefit of around 13.8. If we talk about the investigator assessed PFS, quite similar. Hazard ratios are slightly more better. But again, it is mirroring what we saw for the independent committee review. If we talk about the subgroup analysis, as you can see, majority of the patients are showing benefit. Again, the one which is very close to the hazard ratio line, probably those patients are underrepresented, as a lot of elderly patients are underrepresented in majority of the clinical trials. So more than 65% of the patients were only 28 out of 68 here, you can see. And that is why this confidence interval is wide and hazard ratio is 0.92. But apart from that, almost all the subsets are showing a statistically significant benefit in all the subgroups. If we talk about the response rates, the confirmed overall response rate was 85% with a 15% CR as compared to 8.5% CR and response rates of 78%. The median duration of response were also longer with the combination pertuzumab plus TDXD, which is 39 months versus 26 months. Overall survival events are too few. Only 126 events have been reported. As you can see here, it has the early OS data suggests that maybe at a longer follow-up, the curves have started to separate a little bit. But again, a longer follow-up remains to be seen because a lot of the patients who are treated with Cleopatra-like regime, they will end up receiving trastuzumab deruxtecan in the second line and beyond. So we will be keenly monitoring the data, but early data for PFS is quite encouraging. If we talk about the PFS2, that is also favoring the TDXD plus pertuzumab as compared to your THP regime. If we talk about the safety, I think everybody talks about ILD, the special, the adverse event of special interest that is there. I'll briefly talk about the treatment discontinuation. Treatment discontinuations was numerically slightly lower in the TDXD plus pertuzumab as compared to chemo plus pertuzumab arm. And these are the common side effects. I will quickly skip to the pneumonitis. I think it is mirroring what is seen in the other clinical trials. 12% pneumonitis rate of 12%. We have to be very careful about pneumonitis because it is one side effect which does not, where you do not need to look for the grade 3 or 4 side effects as compared to most of the other side effects, because even grade 1 pneumonitis, it needs intervention. It can be life-threatening if not detected early. So we really have to tread tread gently whenever we are dealing with this drug. We need to understand and we need to educate our patients what are the warning signs of pneumonitis and what action needs to be taken whenever there is an early symptomatic burden of the disease, and a careful monitoring with HRCT chest and a subjective monitoring of PFT by DLCO. Left ventricle dysfunction, again, slightly more common with TDXT plus pertuzumab as compared to THP. So coming to the conclusion, it demonstrated this combination TDXT plus pertuzumab demonstrated a statistically significant and clinically meaningful PFS benefit, which was consistent across all the subgroup, good hazard ratios, median PFS of 40 months, which is unheard of in the first line setting, median duration of response of more than 3 years with this, with 15% CRs, and early OS data might suggest a positive trend towards the combination. And the safety data is similar to what is seen for the in other clinical trials of the said drug. So with that, I think I will conclude my talk. If there are any questions, I'll be more than happy to take. And with that, I'll again thank Dr. Abhinav for this wonderful opportunity. Thank you so much.
Thank you, sir. Thank you for joining us and presenting these abstracts for HER2 positive, HR positive breast cancer, then triple negative, and then HER2 positive breast cancer. Talking about all the three abstracts, I think for all the three we need a little bit more time to put it into our practice. And talking about TDXD, everyone talks about ILD every time. In your day-to-day practice, clinical practice, have you seen that much of ILD with the TDXD? I would like to take inputs from Dr. Singhal and Shefali ma'am as well.
I think Singhal sir can highlight us better. He probably would have used most TDXDs out of us. But yeah, I think I have used it now in around 15-20 patients. It's quite significant. Like grade 1 ILD is quite common. You have to be careful. So what I do in my practice, that if I'm treating, suppose, metastatic breast cancer patient, so usually after 4 cycles, 3 weekly cycles, you tend to do a PET scan. So in between this, after the second cycle, I generally do an HRCT test to look for any pneumonitis. I also advise my test to do the 6-minute walk test. I counsel them about the likely side effects that this drug can cause. We also do DLCOs at baseline and every 2 cycles. And if there is any instance where we find that there is a drop in the DLCO or HRCT is showing some changes, we take immediate action.
So you don't wait for the patient to be symptomatic, right?
If HRCT is showing some changes, you have to consider it as significant. If you give the dose again, it can be troublesome.
Okay. Thank you, sir. Thank you for joining us. So moving on to our next session, Shefali ma'am is here. Thank you, ma'am. Welcome. She will be speaking on role of tucatinib, which is not a new drug, but a new drug for us Indians, because now we can afford tucatinib and we can say our patient that yes, tucatinib is another option. So sequencing in HER2 positive metastatic breast cancer. Handing over to Shefali ma'am.
Thank you, Dr. Abhinav. Thank you for giving that opportunity, and let me share my screen.
Ma'am, I could see the periodic table behind you.
Yeah,
That
this is my my son's room, 11th class, so
that
is why.
just that look gave me a nostalgia.
Nostalgia. Of course, that is why I choose this room for the study purposes and all. This has a vibe actually.
Yes, ma'am.
All
Thank
right.
you.
Abhinav, दोबारा कर
Okay.
ले यार PMT ना.
देखो डॉक्टर सिंगल कैसी बातें कर रहे हो आप. Okay. चलो. Okay. And very good evening to all of you. I hope my slides are visible and I'm properly audible.
Yes, ma'am.
Okay. All right. So very good evening to all of you again. And I think after Dr. Abhishek's talk, much things are clear about the PDXD and the Destiny Breast 09. And we'll be talking something about HER2 horizons and evolving paradigms in the treatment of HER2 positive MBC. And as you all know that the way it started with trastuzumab alone making a difference in overall survival, and then adding on pertuzumab to it, coming of TDM1, and henceforth the lapatinib and capecitabine being replaced, and then we could have that TDXD and tucatinib. So a lot of drugs now in HER2 positive MBC management, and the sequencing becomes a challenge sometimes, because once you are adapted to one regimen, the evolving data suggests that, okay, now this is the standard of care again. So how to optimize the therapeutic sequencing is crucial in expanding the HER2 targeted options. And if we talk about first line for HER2 MBC, Cleopatra has clearly shown a difference if we see over the trastuzumab and taxanes. And this data we all are very well aware of, which extended the overall survival, and that is how it became the first line treatment option for all of the patients. If you see the Cleopatra final results, the hazard ratio of the difference was 0.69, and it improved the overall survival by 17 for a duration of 17 months. It was not seen so far in any of the HER2 positive HER2 in targeted regimens in the metastatic breast cancer armamentarium till now. However, I would say that now Destiny Breast 09 coming up and showing a clear head-to-head advantage over this Cleopatra. That is something which needs to be considered. Now, it showed a difference and advantage over Cleopatra, but now Cleopatra extended to Patina in hormone positive. So that is again going to be a challenge and a difficult decision to make what to choose and how to choose. So if I talk of the first line options, option of Cleopatra remains as a choice. Option of Patina is definitely there for a triple positive regimen. And now Destiny Breast 09, though we do not have a mature OS data, but still it has shown a significant advantage in terms of PFS or a 3-year IDFS advantage. So I think this is going to become a first line standard of care soon. So if we talk of the second line for HER2 positive metastatic breast cancer with no predominant CSN involvement, you have all of these options available, be it TDM1, on the basis of Emilia, you have TDXD on the basis of Destiny Breast 03, and we have lapatinib capecitabine data available. And if we talk of second line with brain metastasis, now brain metastasis is something which we all understand that HER2 positive patients are very much prone to, and in their treatment journey, eventually majority of patients will develop this brain metastasis. So that was something which was an unmet need till now. And that is how the unmet need was fulfilled to a greater extent by the approval of these two drugs, which is TDXD and tucatinib. Initially, there was no recommendation for the prophylactic MRI or imaging to detect these patients upfront. But however, on the symptomatic presentation, we could do all MRI and see if there is a solitary brain met or there are multiple, and accordingly, we would base our decision upon, depending upon the area of presentation, the volume of the disease in the brain. Now, with the approval of these two drugs, that is TDXD and tucatinib, somehow in the small volume, not threatening areas where we want a response without the involvement of another subspecialty, that is radiation. So these two are very promising agents. So tucatinib, capecitabine, and trastuzumab was the experimental arm in HER2 CLIMB study, where it showed a significant advantage. We will come to that slide. And if we see tucatinib, how is it different than other HER2 TKIs, that is lapatinib and neratinib? And you can see that it has a very high HER2 selectivity with a very high intracranial concentration. So it is a better selective, efficacious, and safe molecule to use with. So HER2 CLIMB was a study where it used tucatinib with trastuzumab and capecitabine in previously treated HER2 positive MBC, where the patients have already utilized trastuzumab, pertuzumab, and TDM1, and the brain mets were allowed in this study. And the experimental arm included tucatinib in doses of 300 milligram twice daily with trastuzumab and capecitabine versus the trastuzumab and capecitabine as the control arm. And they included both active versus stable brain mets. Stable brain mets, they took it as a treated brain mets. And if you see the brain metastasis population number-wise, so 48% of the patients were the brain metastasis patients, out of which 29% were active and 19% were treated stable brain metastasis. Intracranial response, if you see, there was a confirmed overall response rate of 47% versus 20% in the control arm. And that is how the overall survival in patients with brain metastasis favored the experimental arm. So the figure was median overall survival was basically 21.6 months versus 12.5 months. So delta of 9.1 months was there actually. Just 1 second, the slides are not okay. Yeah. So if you see the CNS, PFS, and overall survival in patients with active brain metastasis, it was a median overall survival difference of 20.7 months in the experimental arm versus 12 months in the control arm, with a delta of 8.7 months. Now, in the stable brain metastasis, the same difference was there in the experimental versus the control arm, favoring clearly the tucatinib, trastuzumab, and capecitabine. Now, new brain lesion-free survival was actually 11.1 months more than the control arm, that is 24.9 months versus 13.8 months. And the intracranial overall response rate, if you see the TDXD, so I think both of the options are very well valid, and there were small studies which tried to see the CNS response in both of these drugs, and these both are having the impressive CNS, PFS, and overall survival. So yeah. So if we talk of both of the drugs like TDXD and tucatinib, so this was another trial that which tried to see TDM1 if added to tucatinib, whether it makes a difference or not. It was the later study which was planned after the HER2 climb. It is HER2 climb 02 study. I think the difference was whether they could have compared tucatinib plus TDM1 versus tucatinib, capecitabine, and trastuzumab, which was earlier approved to over and above the experimental arm, the control arm, sorry. And that could show us whether that was the superior modality, or if it could have been compared directly with TDXD to say that which one is better. But of course, there are certain limitations on the practical ground. So anyways, HER2 climb 02 tried to see that TDM1 plus tucatinib, whether it is better than TDM1 in the patients who have already utilized the trastuzumab and taxane in any setting. Use of the TKIs to treat brain mets was the exclusion criteria. So now, if you see the HER2 climb 02 PFS, in the experimental arm, it was 7.8 months versus 5.7 months in the control TDM1 arm, and the hazard ratio was 0.64. And if you see the clinical overall response rate and overall survival, it again favored the experimental arm of TDM1 and tucatinib versus the control arm. And the only thing was the toxicity concerns in TDM1 plus tucatinib was as obvious, greater than the TDM1 alone, considering both of them have some of their limitations. So if we talk of the third line and beyond for HER2 positive MBC, so there is no one sequence which is defined, and I think we can individualize if the patient performance status does well till the third line. And again, the tucatinib, trastuzumab, capecitabine, which we saw is approved in this line setting with overall response rate of 40.8% with median PFS of 7.6 months and median OS of 24.7 months. On the basis of Destiny Breast 02, TDXD is also approved in the third line therapy after the failure of TDM1. The OS was 39.2 versus 26.5 months, and the PFS was 17.8 versus 6.9 months over and above the therapy of physician choice. Now, if we see the other options which are approved in third line and beyond, we have neratinib on the basis of NELA trial, which included neratinib and capecitabine head-to-head compared with LAP-CAPE regimen, with a median PFS of 8.8 months versus 6.6 months in the control arm, with a statistically significant t-value. Median overall survival was 24 versus 22.2 months. And here the hazard ratio was 0.88 with the p-value of 0.2. So another molecule, which is margetuximab, is also approved as per the SOPHIA trial. And the third one is pyrotinib on the basis of Phoenix trial. However, these options we do not have access here. And now if we see the refined approach for HER2 positive MBC sequencing, we have all of these options available based upon whether it is triple positive or a hormone negative HER2 positive. We have options with chemotherapy, without chemotherapy, if there is a contraindication to use of chemotherapy. And we discussed about Cleopatra. Now we have Destiny Breast 09 and we have Patina. Now the second line, we have TDXD and TDM1. We have patients with active brain metastasis where tucatinib, trastuzumab, and capecitabine combination showed a good overall response rate, intracranial response rate, and PFS. And in the third line, as we discussed, we have TDXD, we have tucatinib, trastuzumab, capecitabine, we have TDM1, and later lines we discussed all the newer molecules. So I think now we have access to tucatinib, the generic version, pertuzumab, and TDM1. The cost constraint will also be tried to be catered in a better way, and our patients will have a more better access to these newer molecules. So I rest my talk here. If there are any questions, I'll be happy to answer.
Thank you, ma'am. Thank you, for that sequencing. So, talking about your clinical practice, how do you sequence metastatic HER2 positive breast cancer?
So, like I told you, metastatic HER2 positive breast cancer treatment naive depends upon whether hormone positive or a triple positive, because triple positive subgroup was well represented in Destiny Breast 09, and you have Patina for that also. And of course, still the OS data is immature. Both of them will be the option. And once the OS data shows a significant advantage over Cleopatra, I think that will be the treatment of choice. And after that,
So first
once
line THP.
first line till date, we have all three options.
Yes.
Till the OS data is immature. Out of these, Destiny Breast 09 has the most impressive data till date. So if I tend to use Destiny Breast 09, so TDXD is well utilized in the first line. And then I am left with the tucatinib, trastuzumab, capecitabine, or TDM1 plus tucatinib in the second line, which is there on the basis of HER2 climb and HER2 climb 02 data. And after that, so we have no sequencing one over the other. So you have multiple molecules as per the general health condition and the accessibility.
I don't know, but so please.
Yeah, so I think there is no very well defined sequence, as we are stuck up in the EGFR mutated non-small cell lung cancer, that how to proceed. So the same way is happening in HER2. And I think Cleopatra should not be discarded as such. So Patina is a greater way to do, because we have impressive data for TDXD in the second line. But however, one can argue that best foot forward is always the winning game. So if you can delay the intracranial progression with the Destiny Breast 09 type of regimen, then why not? So of course, there will not be one choice at one time. It will be case to case basis.
Agree, ma'am. Agree. So thank you, Shefali ma'am. Thank you so much for joining us and enlightening us for optimal sequencing in HER2 positive metastatic breast cancer. Now moving on
Thank
to
you,
our
Dr. Abhinav. Thank you.
So now moving on to our last lecture of the day. Single is not listening, I think.
Dr. Singhal is busy as usual in the OPD.
Yes, ma'am.
Yeah.
Let me call. Sir. No, he's not listening. So I think
जितना follow up रहेगा वो आप ही से रहेगा या
So, for the last talk of the our webinar, I would like to invite Dr. Manish Singhal sir, who is my teacher also, and he will be speaking on PARP inhibitors in breast cancer.
And the showstopper, right?
And the showstopper, always.
So I'll require some assistance in sharing the slide set.
Gitika, please look into this.
Yeah, thanks. Yeah, perhaps you can make it slideshow? Yeah. So we are discussing the role of PARP inhibitors in early breast cancer. Next slide. Next slide. Well, breast cancer is a common cancer, we know. As a matter of fact, the patient sitting in front of me is also a breast cancer patient. So perhaps they'll be interested in listening to this. Next slide. There's no doubt that a lot of research is being done on breast cancer, so the survival rates are improving. Next slide. But we still need to do some more work in detecting cancers early on in India as well as is being done in the US. Still, we get a lot of breast cancers in very advanced stages. And as the stage advances, the risk of recurrence keeps increasing. Next. Yeah, next. So this is the general paradigm of the treatment which has evolved over a period of time. Now, most patients receive some form of neoadjuvant chemotherapy, followed by surgery, which may be a breast conservation surgery or mastectomy, followed by radiation therapy, and followed by adjuvant therapy. Next slide. So patients, depending on their biomarkers, their risk assessment, the high-risk patients with either HR positive or a TNBC setting or a HER2 positive will receive some neoadjuvant chemotherapy followed by surgery and followed by the adjuvant therapy. So a lot of work is being done on the adjuvant part of the treatment, and many such therapies which have become effective in metastatic breast cancer setting has climbed up the ladder to become a part of the early breast cancer treatment as well, because this has resulted into median overall survival benefit, if not overall survival, at least invasive disease-free survival benefit. Next slide. So the discussion today is about the PARP inhibitors. So olaparib is a recommended investigation for the therapy for germline BRCA1, BRCA2 mutations, both in the adjuvant setting as also in the metastatic setting. Next slide. Next slide. So whom to test for BRCA mutation? More or less, this has become, because there is a therapeutic advantage of doing BRCA mutation, this has become a part of testing for most comers. You'll hardly have a patient whom you would not like to test. Although it is important to mention that there would be some patients who may not be requiring to do the test, those who are elderly, have otherwise low risk profile and do not have any strong family history. Next slide. So the incidence is quite varied between different population. It is higher in the Caucasian population as compared to the Indian population, but we do have about 10% patients to about 15% patient who would be deemed BRCA mutated. Next slide. So when to test, it is always important that we test upfront because there is a tendency to otherwise forget about this testing. And so it's important that we test, because there can be implications on the surgical treatment, there can be implications on the adjuvant treatment, and also sometimes on the neoadjuvant treatment as well. Next slide. So we can skip this slide. Next slide. Next slide. So there are several clinical and pathological features which are associated with risk of recurrence. Of course, the stage is important. The number of positive nodes is important, whether the patient is hormone receptor positive or TNBC. The high CPS-EG score, which is important to select patients for olaparib. This is a clinical pathological scoring system which also takes into account the estrogen positivity and the grade of the tumor. And of course, molecular testing is also important, which takes into account Oncotype DX, which gives you an idea about the hazard ratio for the risk of recurrence. Next slide. Next slide. Yeah. So coming to olaparib, this was studied in the Olympia study where they took some patients who received neoadjuvant chemotherapy. Among the TNBC setting, you have to have a non-PCR. For the HR positive setting, you have to have a non-PCR and a CPS-EG score of more than equal to 3. In the adjuvant setting, any patient with TNBC who received surgery upfront have to have a T2 and above disease or a node positive disease. In HR positive, they should have more than equal to 4 lymph nodes positive. So these patients were randomized to olaparib 300 mg BID versus placebo for about 1 year. Invasive disease-free survival was the primary endpoint. Next slide. So these are the patient demographic. Mostly BRCA1s, about 28% were BRCA2. Very rarely is BRCA1 and BRCA2 both together. About 62% were premenopausal, and bilateral breast cancers were about 4 to 3%. Next slide. So this is the grading and the staging system and the staging of these patients. And you can appreciate that mostly were stage 2A, but mostly there were hardly any stage 1 patients, and mostly there were grade 3 patients, so higher grade patients. Next slide. So the invasive disease-free survival was improved by almost 42% reduction in the risk of invasive disease-free survival event, with almost at the end of 4 years, it improved from 77% to 85%, which is about 7 to 8% delta. At 4 years, the invasive disease-free survival was 75.4% to 82.7%, almost about 7% delta. Next slide. Also, the overall survival was improved, although this was about 3% or so, but this was certainly improved by 3 to 4% improvement in the overall survival also. And this was statistically significant. The p-value was 0.009. Next slide. Over 7% or more patients treated with adjuvant olaparib were free of their distant recurrence. So this is a distant disease-free survival graphs. Again, there was around 7% delta in the improvement at about 42 months. That is 4 years of follow-up. Next slide. So distant disease-free survival with adjuvant was again improved from 79% to almost 86.5%. Next slide. Not only this, even second primary non-breast cancers were halved, and also second primary breast cancers were also reduced with the effect of olaparib. So it perhaps has some preventive effect on new cancer developments as well. Next slide. So these are forest plots. So be it platinum use or no use, HR positivity, BRCA positivity, or which BRCA positivity, all primary endpoint, the point estimates is well within the unity line, and they are favoring all subsets. Next slide. And this is for distant disease-free survival as well. So all the point estimates are well within the unity line. Next slide. This is for the overall survival benefit. Again, all the point estimates are well within the unity line. Next slide. So more than 70% patients completed the treatment. Coming to toxicity of the treatment, about 30% patients. We know that olaparib can be sometimes tough for some patients, which can cause fatigue, sometimes upper GI symptoms, and sometimes anemia. Next slide. Next slide. So most of the adverse events, as said, that there were about 24% patients who had grade 3 events. About 1.9% had grade 4 events. Permanent discontinuation of the treatment happened in about 10% patients, which was about 4.6% in the placebo. So about 5% patient would have permanently discontinued the treatment. Next slide. So nausea, fatigue, these are the most common side effects. Anemia, and about 9% patients did have about grade 3 anemia, which can necessitate stopping the drug, going down on the dose, or sometimes even holding the drug forever. Next slide. So number of patients requiring blood transfusion, for grade 3 anemia, about 5% patients received 1 unit of blood transfusion, and number of patients receiving 2 transfusions is about 1.4%. I think in clinical practice is slightly more than that, but many of these patients may not actually require blood transfusion. If you're monitoring them well, you can stop the drug, allow them to recover, so that you can avoid a blood transfusion. Next slide. Coming to fatigue severity, fatigue is definitely there, but usually as time passes by, the fatigue usually becomes normal. Next slide. Coming to diarrhea, nausea, and vomiting, definitely there is a dip because of olaparib in these outcomes in patient quality life. but it tends to become better with time. Next slide. So NCCN has quoted it that olaparib is listed as a preferred regime for HER2 negative high-risk patients with germline BRCA1 and 2 mutation, and olaparib is recommended as an option for 1 year after neoadjuvant or adjuvant chemotherapy, and the recommendation is for select TNBC patients as well as HR positive patients. Next slide. So ASCO practice guidelines. So TNBC more than 2 centimeter or any axillary lymph node, HR positive with 4 involved lymph nodes. And for the neoadjuvant therapy, those patients who have a residual tumor, and in HR positive, those patients who have a residual disease and have a CPS-EG score of more than equal to 3. And of course, they have to have a germline BRCA1 and BRCA1 or BRCA2 mutation. So St. Gallen guidelines also corroborate the same thing, that olaparib should be a part of this part of the therapy in adjuvant setting for the eligible population, and they strongly endorse the use of adjuvant olaparib. Next slide. So based on other targeted therapy options, of course, this is not that we need to discuss, but yeah, there is disease-free survival, invasive disease-free survival, as well as overall survival benefit. And it is very similar to what we achieve with trastuzumab. We are using many other things in the adjuvant setting where overall survival benefit has not been shown, but olaparib has shown. So this is just to reflect that many such therapies which do not show overall survival benefit, yet we are doing it, then why not olaparib also? With that, I thanks for the attention, and happy to take any questions.
Dr. Singhal, I have one question, please. So, what is your experience in coexisting HER2 positive and BRCA positive? So, have you come across any data or any patient in your practice? And the second thing is, then how do you sequence, I mean, PARP inhibitor in such scenario? Any idea? Any thought?
Good question. HER2 positive patients being BRCA positive is very rare. It's not that it is not known, but it's very, very rare. And that is one thing. How do you sequence? Of course, HER2 is the driver over here, and you've got to target the HER2 more often than not. Whether you can actually target BRCA mutation also along with the HER2 target, well, you can do it if you have a peculiar situation like that, but this combination is not very common. And we don't have any set guidelines to choose your therapy. I think you have to use your own clinical acumen to choose therapy. But since HER2 is the major driver in the adjuvant setting, I would rather do proper HER2 target therapy in the neoadjuvant setting, and then combine it with the appropriate adjuvant treatment for the HER2 target. And in case you have a situation where you have a metastatic setting and you would like to give only HER2 target and a BRCA olaparib based therapy, you can do that if the patient is not very willing for chemotherapy or you want to use it as a maintenance therapy. But as I said, this is not very common, it's very rare.
Yeah. So why I was asking is because recently we have come across a couple of cases where the tumor heterogeneity was seen. So same patient expressing a triple negative profile in one biopsy, and if you biopsy maybe some outside thing, the slide was reviewed, it was HER2 positive. And sometimes when we see that there is a small tumor and we tend to biopsy node, the expressions are different.
If you have a clearly HER2 positive patient, P+, without doubt, and the patient is very high positive, you are very unlikely to have a BRCA mutation. But if you have a borderline-ish HER2, HER2 is just 1 point, it's just about coming.
If it is FISH positive, say IHC2+, so sometimes the heterogeneity is there.
Then perhaps you know that perhaps this is likely to become HER2 negative very soon. And if you have a BRCA mutation positive, then you're likely to target the BRCA rather than targeting the HER2 too much. You know that within the HER2 population, unless until HER2 has changed the game, there's no doubt. And HER2 has changed this game quite much. But then if you have that type of a population, then you got to have that sense that which is driving the disease, whether it's the HER2 positivity which is driving the disease or it's the BRCA positivity. And then you have to choose your therapy accordingly.
Sure. Right. Thank you.
Thank you, sir. Thank you for joining us. Thank you, ma'am. And I think always whenever we even see in HR positive, also if we have to, HR positive and germline BRCA positive, again we target the BRCA only, because whoever the strong driver is, we have to target that. So if it is HER2 positive germline BRCA, I think HER2 has to be targeted. And what about sequencing in HR positive? I think you must be giving olaparib before adjuvant Abema or
Nobody knows this answer. Of course, if you have a disease which has a proper target and is not all comers like CDK4/6 inhibitors, you are likely to use PARP inhibitors. And as such, BRCA mutated patients have a more aggressive course as compared to the non-BRCA mutated. Not to say that patients who have who are in a metastatic breast cancer setting and they have BRCA mutation positive, they ought to be used with ought to be treated with HR positive hormone therapy plus CDK4/6 inhibitors, followed by olaparib if they recur again, if they progress again. It's not the other way around. So I think one cannot say that in the adjuvant setting, when you are preferring hormone therapy plus CDK4/6 inhibitor in an MBC setting, BRCA mutation positive, then why would you favor olaparib over adjuvant abemaciclib or abema therapy, right? So the jury is still out. I think we have not written the final word on it, but it's up to you whether you like to use a BRCA mutation and then top it up with CDK4/6 inhibitor later on. Thankfully, it's not very common scenario to find such patients, but then if you have a patient, then you are okay to choose between the two.
Yeah, sir. I mean, the randomization for CDK4/6 inhibitor was allowed from 8 to 10 months post the completion of the therapy. So I think if it is low hormone positive, where you are really not sure whether, I mean, though I agree with you, there is no data, but is it better to give PARP inhibitor in that scenario, first complete 1 year and then start on CDK4/6 inhibitor? Because you can combine
you're
olaparib
right.
with hormone.
One can do it that way.
Yeah.
One can do it that way also.
Yeah.
So, okay. So coming to the end of day 2 of our webinar, thank you, sir, and thank you, ma'am, for joining us. It was a wonderful gathering both the days. And Geetika, can we conclude?
Yes, sir. So, thank you, Dr. Abhinav, Dr. Shefali, and Dr. Manish to join the webinar. And thank you for the academic partner, Roche and Merck, Zydus, Ares, Lupin Oncology, Sun Pharma, and BMS. Thank you so much, sir. Thank you so much, Hala Kank Test Support. So, can you close the meeting now, ma'am, sir?
Thank you to the organizing team, Tech Support, Horizon. Thank you so much.
Thank you, sir.